Hello, my name is Jeff Taylor with the AIDS Treatment Activist Coalition, and I'm here at the 20th anniversary of the Conference on Retroviruses and Opportunistic Infections here in Atlanta. And it's the very close of the meeting, and we're here with Dr. Michael Dube from the University of Southern California and Dr. Pablo Tebas from the University of Pennsylvania. And we're going to be talking about metabolic complications in HIV and what happened this year. So, gentlemen, what kind of stood out for you this year in the conference in terms of metabolic issues in HIV?
Well, I focused my attention on the cardiovascular aspects. There was a great deal on cardiovascular risk and cardiovascular imaging and some things that really spoke to the pathogenesis of cardiovascular disease. Among the most interesting presentations were a presentation from the MACs, where they did coronary CT angiography on a large number of men in the MACs, both HIV infected and control subjects, as well as a cardiovascular imaging study from Harvard, from Steve Grinspoon's group. And both of these suggest that the plaque, the buildup of cholesterol and other substances in the blood vessel wall is somewhat different in patients with HIV. Steve Grinspoon's presentation really pointed out the high prevalence of non-calcified plaque, both plaque that is increased vulnerability to rupture. When you have a heart attack, you generally, what happens is you have a plaque that ruptures, and then that causes platelets to stick and the blood clot, causing loss of blood flow to part of the heart muscle. And the apparent composition of the buildup in HIV positive men was much different. That there was less calcium involved in that, and that suggests that the whole process that's driving plaque buildup in the walls of the arteries is different in people with HIV as opposed to men without HIV. They had a very nicely matched control group of healthy individuals, and in fact they were supposed to be healthy. So this is plaque buildup in the blood vessels that they found in people without a history of heart disease. So there's this underlying increased risk of plaque buildup in the wall that with plaque that is more prone to rupture, and that is something that we have to take very seriously when we're developing our interventions and trying to determine what the risk of cardiovascular diseases in our patients.
So given the differences between HIV and those without HIV, do they think people with HIV are going to be at greater risk and have to be more aggressive in managing cardiovascular risk?
There was a couple of presentations from the VA cohort and showing that patients with HIV have a higher risk of cardiovascular events, renal failure, chronic kidney disease, and tumors than the population of the VA that doesn't have HIV. It's sort of a match control in the aging study. These complications doesn't appear to occur earlier. They happen at the same time, but HIV patients are at higher risk. And the question is, how much is HIV and how much is lifestyle issues, higher prevalence of risk factors for cardiovascular events? It's a fact that patients with HIV has more cardiovascular events than patients without HIV. Mm-hmm. How much of it is related to HIV itself, the treatment of HIV, or lifestyle things that are more common in patients with HIV is the question. There was a very nice study from the CDC matching patients with HIV to the general population of the US and showing a higher incidence of smoking, which is one of the easily controllable factors that predispose people to have cardiovascular events. But if the plaque is more unstable and there are more risks in more lifestyle issues that are associated with risk. This is something that patients with HIV and their physicians have to take care of.
One of the things that they weren't able to say definitively in these studies was whether or not it was primarily HIV disease that was responsible for the increased risk or the treatment for HIV disease, because these were cohorts that were largely on antiretroviral therapy.
Yeah, that's one of the big questions. I think the frequency of MIs, there was another cohort, it seems to be lowering a little bit, at least in Europe. So I think it's a sign that providers and patients are paying more attention to this in the last few years. So from the early 2000s till now, I think this has become people have become more aware of these issues and being more aggressive managing traditional risk factors. The question is, do we need to do something extra? Yeah. Because HIV by itself might provide an increased risk.
Corlin Heilman from Case Western, Grace McComsey's group, presented 96-week data of a cohort of healthy HIV-infected individuals who are not on antiretroviral therapy that they followed for 96 weeks now, and they did serial imaging of their carotid arteries and found in these untreated individuals who generally had low viral loads and high CD4 counts, thus they were not being, for whatever reason, treated, that those individuals did not have any increased risk of worsening of their carotid imaging over a 96-week period after presenting 48-week data last year. So that's one piece suggesting that perhaps, at least in individuals that are at low risk for HIV disease progression with high CD4 cell counts and low viral loads, that they may not be at considerably increased risk of vascular disease.
And that might suggest that the treatment is the main factor by increasing lipids or mediating some inflammatory or the lack of decreased inflammation associated with treatment that might mediate the more rapid progression of atherosclerosis and HIV, or might be that that population is so selected that because they have HIV disease but it's not progressing, is so selective that maybe they are somewhat protected against atherosclerosis. Some of the markers that predict no progression of HIV, like genetic markers like heterozygosity for CCR5, also predict a lower risk of atherosclerosis. So people that are heterozygous for this CCR5 deletion, they have less incidence of atherosclerosis. So when you are selecting a population a lot, sometimes it's difficult to know if what you are seeing is the lack of effect of HIV or is some genetic marker that is associated with both things. So, but it's a nice study.
Yeah, they did report in these individuals that they did have higher inflammatory markers, which was interesting. A small study, but over time it's going to become less relevant as the push is to have everybody on treatment.
Yeah. A lot of talks during this meeting about inflammation and very descriptive, a lot of cohort studies trying to figure out why patients with HIV, in spite of being controlled with antiretroviral therapy, have persistent markers of inflammation, and what is the meaning of that? What is the association at the end with that? So several studies today, in fact, presenting high levels of IL-6 associated with mortality, increased mortality. D-dimer has been shown before. To my surprise, at least cellular markers of inflammation were not associated with some of these bad outcomes, which traditionally everybody's talking about HLA-DR, 38 markers of inflammation. Those were not associated with outcomes, although they were measuring specimens that have been frozen for almost a decade. So you wonder if the specimens were good enough to look. So it seemed that serum markers were better predictors of outcomes. But all of these studies are associations. You never know what is cause and what is effect.
Can you tell us which markers appear to be the better predictors of?
In most of the studies, the theme was around IL-6 and D-dimers and coagulation markers. but IL-6, I think, and TNF, is that right? That's my impression.
IL-6 and D-dimer in particular.
The problem is this is not like CD4 or viral load. We know they are associated with outcomes. It seems that the whole field is looking for a good surrogate marker. Because if we have to design studies to do something about this, you want to not have to. It's like the old HIV era, you know. Yeah. You don't want to wait for the event. You want to have something that is going to be a good surrogate marker. But I think the cardiology field is going away from that. So we don't like surrogate markers because when they try to use that surrogate marker and they look at the outcomes, there is no protection. So I don't know what's going to happen. But our field seems to be looking for a good surrogate to use in shorter trials. I don't know if the cardiology field is going that way, but what do you think?
Yeah, I'm pessimistic that there will be any surrogate marker that is going to improve on looking at the classical risk factors. That, for example, IL-6 or D-dimer, while they're important and may indicate enhanced inflammation, it's really the classical risk factors that will predict most of the cardiovascular risk. These blood tests like IL-6 and D-dimer have a lot of variability. Your cholesterol, for example, will not vary a tremendous amount from day to day, but these other things will. And while they're important, and they're found to be important in large population studies when they pool a lot of data together, for an individual, I'm pessimistic that they're going to be very useful in helping risk stratify who needs more intervention and who doesn't. That doesn't mean they're not going to be useful in clinical studies to see what sort of interventions will reduce inflammation for the group as a whole, but predicting responses in individuals is one thing that's much different entirely.
You mentioned the use of statins and inflammation and how those intersect. Have there been any intervention trials that were reported on that?
It was a nice, Grace McComsey group had a rosuvastatin trial using a fixed dose of rosuvastatin, 10 milligrams, and so the study used the same dose for everybody, and we know that protease inhibitors increase the levels of statins, but it was stratified by protease inhibitor use. It's a sizable study. I mean, I think it was 180 or 170 something patients randomized to get this or not, and they look at a bunch of inflammatory markers, and nothing really changed that much with the rosuvastatin. There was some effect on markers of monocyte activation, which CD14, soluble CD14, and then some monocyte inflammation markers, which lately seems to be becoming more relevant for progression of atherosclerotic disease. And I think Grace was trying to repeat, in short, the Jupiter trial that gave people with inflammation rosuvastatin, and it was associated with improvements in cardiovascular events. I don't recall in the rosuvastatin trial if there were improvement in these surrogate markers that relate to cardiovascular events. But here
there was in CRP.
There was in CRP, but in Grace didn't show any improvement in CRP.
No. Grace's trial is targeted at individuals that we wouldn't normally give statins to, but were selected by a high CRP or a high level of cellular activation, and it turned out that about half the people that got in the trial got in because of a high CRP, and another half that got in as a result of having high levels of cellular activation. And the results were similar in both of those groups. So it may be that it is, the lipid lowering effect of statins is more important than their anti-inflammatory effect, or their anti-inflammatory effect is a result of their lipid lowering effect rather than direct effects. So it was really disappointing to me to see that there was such little movement in the inflammatory markers that we think are so important.
Yeah, I don't think this kills statins as an anti-inflammatory because, it's 96 weeks, but, these surrogate markers are not good markers of what is going to happen down the road. I think we need there will be, the National Institute in NHLBI is looking at a clinical trial trying to test the hypothesis of inflammation, which mediates some of these outcomes. And they are using a low-dose methotrexate as an anti-inflammatory, pure anti-inflammatory, no effect in lipids, to try to answer the question, is this inflammation associated with bad outcomes, or is just...
No, is that in HIV or just in...
This is in the general population, 7,500, and the ACTG, 7,500 study, real cardiology studies, big size. And in HIV, I think the ACTG is going to open a study very, very similar. How big is the N in that study? Is 400 or something like that?
It's considerable. I believe it is 400, yes. And they're going to be looking primarily at safety in that study, but they have a crucial secondary endpoint of flow-mediated dilation, brachial artery ultrasound as a measure of blood vessel function to see whether or not the anti-inflammatory effect has any effect on blood vessel function.
That's an important trial that it was going to take a couple of years to see the results of the large trial, and I think that will bring some light to the issue of inflammation and bad outcomes.
That study is coming. It's in the last stages of review in the AIDS Clinical Trials Group, and something that should get started this year.
So something for patients to look for.
Yes.
clinicaltrials.gov.
I think, this field has been characterized for such huge contribution of patients to the improvement of the care and development of new drugs, of new strategies. And inflammation and outcomes in people that are fully suppressed are so critical. This is the question now. So it's important that patients that are interested and willing to take the risk of participating in a trial get involved with these studies, because we will learn a lot of how to treat other people.
Well, I think patients will come forward. They always have in the history of HIV.
Yeah,
and so many don't qualify for other studies and are looking for trials like this that are addressing the issues of long-term survival. So I'm sure it'll accrue well. To switch gears a little bit, you mentioned earlier the increasing rates of kidney disease in the VA cohort. And as people age, obviously this is a concern, especially since we rely so much on tenofovir. And now cobicistat has entered the picture. What are we seeing in terms of renal toxicity in people?
I think the good news on in this meeting has been the first data on TAF, the new tenofovir, that it seems to be less toxic. And the dose, although it has the same antiviral activity, because that drug tends to concentrate inside the lymphocytes, the cells that replicate the HIV, but the total dose is 10 milligrams. So the renal toxicity, which is mediated by levels in the kidney, is going to be, hopefully, we'll cross our fingers, and is going to be less. And they presented some data. It looks good, virologically equally potent as tenofovir.
And suggestion that it's better from the kidney standpoint.
Yeah, and suggestions. Yeah, you're absolutely right.
And also data that suggested it was better from a bone standpoint as well than standard tenofovir.
We still don't understand very well why tenofovir mediates the bone loss. Why it's a little bit different from other antiretrovirals, a little bit worse, and maybe it's mediated through the kidney thing. So it's a reaction to what's happening in the kidney.
Well, certainly when people start tenofovir, they notice a difference in a decrease in bone mineral density. But over time, has that proven to be a long-term concern?
Well, anybody that when you start antiretroviral therapy, you lose around 2% of your bone mass, which is like going through menopause. And so it's significant. With tenofovir, you lose a little bit more. by 3, or it's always that delta with other antiretrovirals, and is relevant. Then after 6 months, it tends to stabilize.
Mm-hmm.
But losing 2% of your bone mass might be relevant, especially for some people that are at the age of increased risk. And if we have a regimen,
There are data from the VA cohorts
Yeah.
with suggesting or documenting an increased risk of fracture in their cohort study. with
Roger Bedimore's study.
tenofovir. So it's definitely happening. To answer your question, we don't really have a good idea about what the long-term effects of tenofovir are, but there is a study that's starting in the ACTG that's going to go back and repeat DEXA scans on people that had them done early on in treatment studies, so that they can get a good view of what's happening to bone mineral density over a much longer period of time.
Oh, that's good to know. Well, I think we've only touched the tip of the iceberg in terms of metabolic issues, but I'm sure we'll have many more years to explore these issues. And thank you both for sharing your time and your expertise, and look forward to seeing you at next year's CROI.
You're
Thank you
welcome.
very much.
Thanks
Thank you for having me.